Hello, and welcome to Leading the Way for You, a webinar series hosted by Country Meadows Retirement Communities and our sister company, Ecumenical Retirement Community. In this series, we will be providing our senior care experts sharing tips and information on topics that interest you. My name is Kelly Kuntz, and I'm coming to you from an apartment at our retirement community. Today, we will be joined by Dr. Christopher Manetta, who is board certified in both psychiatry and neurology. He began his medical career in the United States Air Force and today provides clinical oversight in psychiatry and behavioral health services for CCS Healthcare. Dr. Manetta will present an overview of mental health in the senior population and explain why mental health services can be a vital component to a collaborative effort with a senior's primary care physician. He will also share information about common ailments, causes, and treatments. It is my honor to introduce Dr. Christopher Manetta.
Thanks, Kelly. I appreciate it. And it's an honor for me to be here and talking today about something I hold near and dear to my heart, and that is not just psychiatric care, but really access and medical care as it relates to our geriatric patient population. So as Kelly said, I'm Dr. Manetta, and I oversee all of the behavioral health and psychiatric services for CCS Healthcare. And what I thought would be really helpful today was to provide maybe just a brief overview identifying one, what's the problem, right? What are we dealing with? How do we go about defining it? And really maybe what are some of more of the group dynamics or cultural dynamics that perpetuate that problem a bit? And then how do we dive in, right, as a community, both from a familial standpoint as well as a medical perspective, to really help in attacking the issue at hand here, to really promote quality of life, mitigate risk, improve outcome, do it in the safest way possible at the lowest costs available. If you notice on this first slide here, I put up kind of a very simplistic diagram, right? And this is really what we want our future state model to look like. If you look across the board in current state treatment for most medical needs, let alone psychiatric issues, what you tend to see is a very traditional approach that can be a bit fragmented and siloed, where a patient goes first to see their primary care clinician does what they can to address the individual's needs. But then if it's something outside of their scope, they're turfing it to a specialist. And then that patient and or family kind of gets put in the queue with the specialist, and they're in line, so to speak, right, and waiting maybe months before they can get seen by the specialist. And then it's not always a case where the communication flow circles back to the primary care clinician to kind of close the loop. And so what you tend to see happen, to no one's fault, but just from the systematic errors that occur, is you tend to see folks kind of fall through the cracks. People are more at risk for poor adherence to treatment, poor outcome to treatment, and clinicians themselves are dissatisfied because they want what's best for the patient, but they kind of are inundated and overwhelmed. And so the future state here is to kind of develop more of a collaborative care approach, right? And so that diagram, which I'll be coming back to periodically throughout the talk today, is really intended to illustrate what that looks like from a behavioral health or psychiatric perspective. And if you do look at it, I do just want to kind of emphasize that the patient, right, the resident, is the hub of that wheel. This is a patient-centered approach, right? So all of the tools and clinicians and entities that surround that patient are all dedicated toward really promoting that individual's health. So we'll be coming back to that. But let's kind of get a bit more into maybe some of the statistics to identify the problem. Right now, we're really on a precipice of kind of generation kind of entering that geriatric phase of life, right? And so geriatrics are typically defined by the age of 65 years of age and older. We've all heard of the baby boomers, right? The baby boomers are really starting to enter that segment of life. And so it's greater than 80 million people across our country are now transitioning into the geriatric patient kind of quote unquote population, as it's the fastest growing segment of the US population. And up to 25%, maybe a little bit more even, of those 65 years of age and older will experience or are experiencing some form of mental health problem. And so mental health problems can come in all different shapes and sizes, but just to list the most common: depression, anxiety, pain or chronic pain and all of the associated psychological factors at play, sleep disorders, post-traumatic stress disorder, substance use disorders, psychosis, and then we start to kind of get into the realm as well as neurocognitive disorders, or that's more of a fancy way of kind of saying dementia. And so when you look at that, then you have to parse out dementia versus delirium. And sometimes you can have delirium in an elder patient as a result of poorly managed or out of control underlying medical conditions that can present in a more confused or disoriented state. Sometimes that gets misinterpreted as dementia, but frankly, that delirium is more of a medical emergency that would require more acute medical intervention, as opposed to dementia, right, which comes in a lot of different types, the most common being Alzheimer's type. And that's more of an insidious, slow development that you tend to see over years kind of progress, where people lose their cognitive functionality. They become more deficit in things like attention, concentration, orientation, ability to calculate and execute day-to-day activities. And so when you look at that number, 80 million people, up to 25% of those 80 million will or are currently going to suffer from some form of mental health problem. You start to wonder, oh my gosh, I'm overwhelmed by those numbers, right? And you start to wonder, how in the world are we going to help address that? Especially when you think about that traditional model of care that I just a minute ago described for you. When you start to parse out the data even further, what you start to recognize is that the geriatric patient population is a very vulnerable patient population as it relates to bad outcome related to psychiatric illness. So people 85 years of age and older have the highest suicide rate, completed suicide rate of any group. That doesn't mean they attempt more than other groups. It just means that when they do attempt, they're really good at it, unfortunately. And they tend to be very successful in completing suicide. And it's estimated 66% of assisted living residents will have some form of neurocognitive disease or dementia. More than 25% of those with dementia will develop some form of psychiatric symptom, such as depression, anxiety, or psychosis. Now what we do is, you might not have any psychiatric history whatsoever, and you're hitting the twilight years of your life, and you start to develop cognitive decline, which morphs slowly into maybe some form of dementia. What can come as a result of that primary diagnosis of dementia may be some form of psychiatric symptom or illness, which would require treatment. The unfortunate thing is it's estimated that less than 50% of these conditions are adequately treated. As often is the case, that these cases present complex diagnostic and treatment challenges with limited access to appropriate resources. So all roads distill kind of back to that traditional model where you have kind of the doctor-patient relationship. That's the primary care doctor and the patient. They interface, but perhaps that primary care clinician is not equipped or well-versed in treating whatever might be going on in that individual, and so they have to send that individual to a specialist. And then maybe that happens, maybe it doesn't. And so there's a lot of access problems and clinical problems that occur as a result of those barriers to care. 60 to 80% of primary care medical visits are problems related to psychosocial issues, with a chief complaint that's psychiatric in quality. So that's a lot. A lot of these folks are going to first be visiting with their primary care clinician. They're not necessarily going to have the ability or access to a specialist like myself who could do a deeper dive with them off the get-go. So the demand for psychiatric services, if you really do the numbers, do the simple math, exceeds the capacity that's out there. Educational programs, training programs, residency programs could continue to produce the numbers that they are as it relates to specialists, particularly psychiatrists, but it's never going to be enough. It will never be enough to keep up with the cadence of the demand. And so we have to start thinking about ways that we can start to implement care differently for the more common ailments, such as depression, anxiety, and the like that I listed before. Many chronic health problems with a known physical etiology need concurrent treatment for a behavioral health problem to gain optimal outcome. We as human beings, we are very complex organisms, right? We don't live in a vacuum. It's very difficult when you're trying to understand what's going on with an individual to just be able to kind of categorize it into different buckets. Often is the case that an individual is suffering from one ailment, which then gets intertwined into another ailment, and then that snowball effect continues. So the way we really work to conceptualize things is from a biological, psychological, and social formulation or conceptualization. So some examples of this might be you have an individual who is coming in complaining of sleep problems, or you have an individual coming in complaining of chronic pain problems. These aren't maybe on the surface seen as psychiatric issues, but inevitably there's going to be a component of psychological, maybe social, or even biological coming into play with those things, right? So we have to recognize that medical care, psychiatric care are essentially one and the same. And you can't really fix one without addressing it all. And so it really requires more of a holistic approach. There's not always going to be perhaps a medication that's going to be able to help. You might have to start to look at some of the non-pharmacological treatment options, taking into consideration environment, social support, social connectivity, one's ability to kind of reach out and ask for help. Maybe their family history is significant for dementia, and they just know they have a predisposition genetically to develop some of these things. Or unrelenting, untreated chronic pain, and how that can ultimately turn into pretty debilitating and severe depression in some. So again, many chronic health problems with a known physical cause need concurrent treatment for a behavioral health problem to gain an optimal outcome. So if I haven't scared you enough, right, with that, my point there is to really emphasize that there is a problem out there. There's a growing trend in the numbers, and the way that we're providing care may not be enough to kind of keep up with that demand. So that supply and demand curve are pretty much inversely proportional to one another. So what do we do about this, right? What's the proposed solution? Lots of people have lots of opinions about this, right? But I will say one approach that has been proven to be very effective, I believe there's been over 80 plus clinical control trials looking at this clinical model, is that called the collaborative care model, which really is, again, a fancy way of kind of saying, let's start to integrate behavioral health services in certain treatment environments or certain living environments to really help, one, capture it when it's happening sooner than later, 2, promote access if it does require more treatment, and 3, do it at a safer way at less cost, where the primary care clinician really feels better equipped to be managing these things because they have a subject matter expert at their disposal almost or pretty much in real time to help address the issue. So the past couple of decades, the Centers for Medicaid and Medicare have really started to take a closer look at this because of the public health concern, because of the population health management concern. And what they did was they partnered up with 2 pretty large entities, the American Psychiatric Association and the Academy for Psychosomatic Medicine. And they started to really kind of put their heads together to develop a model that perhaps would attack those tenets that I was listing for you a second ago. So over the past decade, the integration and coupling of behavioral health and general medical services, right, primary care services, has been shown to, 1, improve patient outcomes, 2, be more cost effective, 3, reduce stigma related to mental health, and 4, improve clinical experiences of patients, clinicians, and in these circumstances, their families as well. And so this is an impressive model, right? Because it does the no-brainer stuff, right? We want to make clinical treatment higher in quality, right? We want our outcomes to be improved. But then it also starts to identify the attitudes that are involved by maybe the patient, by maybe the families, as well as the clinicians, because physician burnout's a real thing. It is a real thing, and it can lead to bad care. And it starts when physicians start to feel dissatisfied or feel like there's a lot of barriers in place that prevent them from providing the best care that they can. And then that can morph into a lot of different things. But what this model does is it really highlights the fact that when people collaborate, when they dialogue, when they start communicating, that everyone starts to feel a little bit better about the problem-solving experience. Sometimes when we're facing a problem that's not getting better, boy, that can evoke a lot of anxiety, a lot of frustration, a lot of feelings of helplessness. And again, that can then transfer into feeling really dissatisfied overall. And reducing the stigma, well, again, talking about these things openly in a transparent way is really the best approach to that. And I've seen that in every setting that I've worked in, from the military, where suicides were a real serious problem because people weren't feeling comfortable enough to talk about things, to civilian life, where that stigma is real. Right? We have a real strong tendency to be our own worst enemies when we're feeling bad about ourselves or recognizing that something isn't quite right, but maybe we're not able to put it into a language that we could understand. So going back to the collaborative care model and citing the research here, right? There's research spanning primarily the past 3 decades. Really identifying this one model, the collaborative care model in particular, as being a very effective and efficient way in delivering integrated care. Integration care. That's more than just being co-located, right? And if you think about that diagram that I showed you at the beginning, that's more than just 2 people being in the same location at the same time. There's a dynamic that's actually taking place between the 2. So a report came out called The Dissemination of Integrated Care Within Adult Primary Care Settings, the Collaborative Care Model. And what that report did was it really reviewed the current evidence base for collaborative care and the essential implementation elements with examples and lessons learned as to how you go about implementing this, right? So just to provide you a little bit of a historical perspective on this, this model was first stood up in primary care clinics. So these were outpatient adult primary care clinics where they started to realize, wow, we're seeing 60 to 80% of our folks presenting with some form of psychiatric issue. And the primary care doctors really did not feel comfortable adequately addressing this. So what they first started to do was integrate a behaviorist into those primary care clinical settings. What they found was, wow, that really helped in a lot of ways, all the ways that I listed before. And they used evidence, they tracked it empirically, they were able to really quantify those improvements. Well, then they started scratching their heads and saying, well, if it's working here, wouldn't it work in other patient populations, in other clinical settings? And so slowly you've seen it expand and grow into your more vulnerable patient population settings. I'd be remiss if I didn't say that even to this day, the geriatric patient population is not able to access this kind of clinical model across the board. And so CCS Healthcare, in partnership with Country Meadows, has done a phenomenal job in allowing us to stand this up within their communities. Because if you were to go to maybe California or Oregon or Florida or Texas or Missouri or Wisconsin, any other state, you're not necessarily going to find behavioral health integration in senior living communities. It's really not a common practice yet out there. My hope is that it begins to grow and really lateralizes across the country. But it's still primarily focused in adult ambulatory primary care clinics where you see this model. And so I've been very pleased and proud for us to have successfully stood up this model within the senior living communities that we support, and primarily in Country Meadows. And we've seen tremendous success as it relates to accessing these folks who need the help sooner than later, to supporting the families, to give them psychoeducation and an ability to better understand what's going on, to educate and support the staff at these communities, the leaders at these communities, and the primary care clinicians, who are really the, other than the patient, they are a big piece to this program. And so just in moving on, it's important that you recognize again that when a person has a number of chronic medical conditions, which a lot of the residents in the senior living communities do, that it is almost an inevitability that it's going to impact their mental health. We're now in an unprecedented pandemic state, right, where people have been socially restricted and isolated. That has added a whole layer to this that we're still learning about. We're still trying to wrap our heads around. But really a very pervasive degradation in people's mental health, especially during the pandemic, and especially in those who already are suffering from a number of chronic medical illnesses. So what we try to do is really kind of a stepped care approach, from less intensive to more intensive, to improve the health of the populations we serve, in partnership with the primary care treatment team, while earning the patient and family satisfaction and maintaining a high level of clinician engagement and high clinical outcome. So how does it look, I guess, in kind of day-to-day work or in real life, so to speak? What ends up happening is resident sees primary care clinician. Primary care clinician, resident, and maybe family agree that there might be a psychiatric issue or behavioral health issue that may benefit from a behaviorist and or a psychiatrist getting involved. They then make the referral to the behavioral health team. That behavioral health team is comprised of a therapist and a psychiatrist. The therapist then engages with the resident or patient, family, and staff. They use a number of screening inventories plus a face-to-face diagnostic evaluation to kind of determine what may be going on. Then they staff the case with the psychiatrist. The two of them collectively kind of come up with a treatment plan. That treatment plan gets circled back to the primary care clinician, resident, patient, and or family, as well as staff. And after consent and agreement comes to terms, that treatment is implemented. And then the patient is enrolled in the collaborative care program and is tracked empirically and seen on a monthly basis and monitored as to their progression or lack thereof. And that way intervention can be done in a more sophisticated way, utilizing all the various tools that we have to really kind of make sure their needs are getting met, that they're meeting the treatment goals, the identified goals. So the integration piece really comes down to several core principles here. The first being that this is a patient-centered team approach. As I just laid that out for you, I hope you heard the theme of communication. It was not fragmented or siloed. This was more of a team-oriented effort with shared interest in an effort to help the patient meet their treatment goals. So primary care and behavioral health providers collaborate effectively using shared care plans that incorporate the patient goals. The ability to get both physical and mental health care at a familiar location is comfortable to patients and reduces duplicate assessments. Increased patient engagement oftentimes results in a better healthcare experience and improved patient outcomes. So that's the first core. The second is that this is a population-based care model. So by that I mean we are able to help more people at any given time because of this type of delivery of care, as opposed to just seeing one patient at a time after they've been referred, right? So after a patient's enrolled in the program, we utilize the sophistication of our tools and technology to kind of stratify and triage people. And so it could be as simple as, we haven't seen this cohort of people for 2 months. We need to prioritize them, right? We can do that with the click of a button. We can pull up an entire list of folks who maybe haven't been seen in 8 weeks. Or we might be able to pull up a list of folks who scored really high initially on their depression screener, and we want to really triage them and prioritize them. So that's what I mean by population-based care, is we start to really focus our efforts more deliberately on those who might be in more acute clinical need in the moment. And for those who are in continuation and maintenance phase of treatment, that doesn't mean we forget about them. They still get continuity of care and we still follow up with them. It just maybe doesn't have to be as frequent because they're doing better, they're more asymptomatic, they're more stable overall. So care teams share a defined group of patients that are tracked in what we call a registry. To ensure no one falls through the cracks, practices track and reach out to patients who are not improving, and mental health specialists provide a caseload-focused consultation and not just ad hoc advice. The other core to this is that this is a measurement-based. This isn't some willy-nilly subjective process where we're saying, oh, I think we'll do this, or I think we'll do that. We really utilize tools to empirically measure one's progress or lack thereof. Now, it's very important getting collateral information from families, staff, other clinicians involved. That really helps, again, with that collaborative piece and getting the holistic picture. But what we really want to see here is objective improvement, remission of symptoms. And too often is the case in medical care, especially psychiatric care, where we're kind of just going off a whim or a gut feeling and not utilizing evidence to support our decisions. And so each patient's treatment plan clearly articulates personal goals and clinical outcomes that are routinely measured by evidence-based tools like the PHQ-9, which is a tool we use for depression screening, and the GAD-7, a tool we use for anxiety screening, or the mini mental state exam, which is a tool we use to kind of track cognitive degradation. And then treatments are actively changed if patients aren't improving as expected. So here's, again, bringing you back to the diagram of how it works. You've got the patient in the middle who might be suffering from depression or anxiety. They first interface with that medical provider. That medical provider then communicates with the behaviorist, who then in turn communicates with the psychiatric consultant. Everyone kind of has a powwow. The patient is assessed by the behavioral health care manager, and that patient might be with family, with staff, with hospice, with all the other entities. And then that collective agreement forms to come up with a treatment plan. For our more difficult cases, for the more resistant cases, that's when I come in and I will do a face-to-face assessment. Again, going back to the fact that there's an incredible dearth of psychiatrists, meaning the supply is really low relative to the demand. So there's only one of me, unfortunately, or one of my kind. And so I tend to get pulled in a lot of different directions. So I have to be very strategic with how I manage my time, making sure that I'm treating the patients who need to be treated in most need first. And so for those folks who are really in that level of acuity, I do face-to-face assessments with them for our more resistant cases. And then we can kind of figure out what might be going on and why might the symptoms not be improving. Is this more of a poor prognosis type of condition, or is this something that we could employ maybe a different form of treatment and that individual starts to slowly get better? And that's the satisfaction piece for the patient, for the families, for the staff, but for me, I get a great deal of gratification from that. Many ask about billing related to the collaborative care model. And yes, the collaborative care model is covered via Medicare. Medicare was the governing body that conceived this, and in partnership again with the American Psychiatric Association has helped it grow and expand. And so they do pay for these services. I would say we have stood up the collaborative care model in an effort to better meet psychiatric illness in the geriatric patient population in most of the Country Meadows communities that we support. And I would say we have seen a tremendous level of satisfaction and clinical benefit as a result of it. And so very proud to be part of it. And looking forward to the future as to what this might bring, especially with the advent of technology and things now as a result of the pandemic, right? In an effort to help more people who might be more restricted or have more limited access to care. So with that, Kelly, I'll open it up to questions, and I'm happy to help address whatever I can.
Well, thank you, Dr. Manetta. That was a wealth of information. And at one point, when you were talking about the need for geriatric psychiatry, or geri-psych is a term many of us hear, to what do we attribute this rapidly growing need?
When you think about those numbers that I started to talk with, of 80 million Americans are really on the precipice of entering the geriatric phase of life, 65 years of age and older, the numbers correlate with that, right? If you just take a certain percentage or a slice of that pie, it's going to be a bigger number because the overall population is bigger. On average, it's about 20 to 25%. Will suffer from some level of psychiatric illness or mental health problem. That can also come in the form of substance use disorder or neurocognitive disease, dementia. And so that's really what we're dealing with here. This is a public health, population health issue. And that's why Medicare and other governing bodies like them have tried to work diligently to come up with clinical models where you can deliver care to a larger volume of people in a more efficient way, in a smarter way, and still get great outcomes and still maintain high levels of satisfaction by the patients and their clinicians.
We thank CCS Healthcare and you yourself for supporting the residents at Country Meadows and Ecumenical Retirement Community. That is so very important. What about for those viewers who are watching who are caring for the loved one at home, and perhaps they're suspecting maybe there is some type of mental health issue? Would their first step be to talk to their primary care physician about maybe some of the things they're noticing?
Yes. The first step I always tell families is get support, ask for help, engage in help-seeking behavior. Maybe not only for the loved one, but for yourself as well. I've seen a lot of families tread water, so to speak, with their loved ones for far too long on their own, without having a conversation about it, without soliciting some level of support or guidance on it. And caregiver burnout is also a real thing. And so you don't want it to get to that point, because if it's gotten to that point, it's a little too late. And sometimes it can be really hard to pull yourself out of that and feel best equipped and have the energy to then go seek out help. So the first step would be really kind of leaning into who you trust the most in your life, who you feel safest with in that moment, and then going and likely bringing the loved one in to see their established primary care clinician, who can then at least start doing a medical workup and maybe a bit more of a diagnostic workup as to what might be going on. The geriatric patient population, again, is very vulnerable to medical conditions and disease processes. Many diseases may manifest their symptoms in a psychiatric way, but in reality, it's something more medical or physical in nature that needs to be remedied. And so sometimes by taking them to see the primary care doc initially, maybe it's a hypothyroid issue, right? Maybe they're getting more anxious because their thyroid's out of whack, and they can get that stabilized and you start to see the anxiety get better before just leaping to the fact that, oh, they need to see a psychiatrist and they need psychiatric medication. It doesn't always come to that. I think that's where the stigma comes from, right? Is there's a lot of leaps made to medicate from a psychiatric perspective. And in reality, it's much more complex than that. And so leaning into your primary care clinician as a first step is absolutely the right first step and a safe first step to try to identify what really might be going on.
You bring up an interesting point there. You use the example of the hypothyroidism and how that can contribute to anxiety. As we age, I know that our bodies become more susceptible to certain common ailments that could drive some more mental health issues that go along with those diagnoses. Can you talk a little bit about that?
Yeah, I always recommend and encourage preventative care. So don't wait until it's too late. Establish with a primary care doctor and go in as recommended or as expected to go, and maybe it's annually or twice a year, just to maintain, right? Because as we age, our biology wins out every time, and the mortality rate in this country is 100%. All of us are going to die. We can't deny that fact. But what we can do is preventative care to improve our qualities of lives that we have. And so in most cases, people who consistently and routinely meet with their primary care clinician often tend to do a better job at mitigating overall risk as it pertains to developing more severe conditions that are difficult to manage or treat, especially as it relates to the development of a psychiatric illness. If you've never had one before, but now you're dealing with an organic, biological, physical illness that is coupled with some type of psychiatric issue, that can get dealt with sooner and in the moment. And maybe it's just as simple as getting connected with a psychotherapist and starting to talk through some of the problems first and providing some benefit from a less intrusive manner. The evidence will tell you, cognitive-based therapies, insight-oriented therapies, in some cases can be equally as effective as pharmacotherapy, right? So again, it's less intense upfront to more intense, as I kind of pointed out in that slide earlier. We always try to be as conservative as possible upfront. We are given that opportunity when people are more engaged on a more consistent basis.
As I was preparing for this topic, reading about psychiatry with the senior population, it was interesting what I was learning. How do some symptoms with common ailments present differently in seniors?
Absolutely. Yeah, and especially the more severe symptoms that we tend to see. The fact is, people don't develop schizophrenia in their 70s and 80s. They can develop psychotic symptoms in their 70s and 80s. But if they've lived a healthy mental health, illness-free life. And all of a sudden, at the age of 70, are starting to develop a severe symptom that is well outside their baseline or well outside their character. It's very, very low likelihood that we're dealing with a primary psychotic disorder like schizophrenia, and more likely that we might be dealing with a cognitive disorder, maybe like dementia or some form of delirium, because maybe their electrolytes are out of balance, or they're really dehydrated, or they've been accidentally taking way too much Benadryl because they can't remember when it was the last time they took it. And so they start to compulsively take these medicines with really no insight into it. And next thing you know, they're stuporous, they're confused, they're psychotic. They're not necessarily schizophrenic, right? And so I think it's always important we do a lot of detective work in this. Right? And so if a family member is seeing an acute change in a loved one, that really needs to be medically evaluated to ensure that person's safety and to ensure whatever underlying cause is occurring is going to get fixed or addressed.
What are some common signs or symptoms that as caregivers our families may notice about their loved one that make them think maybe they should mention that to their primary care physician in case there is a mental health issue happening?
That Kelly could be a lecture in and of itself. That's a really good question and a hard one to answer quickly and eloquently, I'd say. I think there's always a difference between dementia and delirium, right? And so dementia, I tell folks, tends to be slow in its onset, an insidious process, right? Where you start to subtly maybe see some word finding difficulties or some short-term memory problems, or, they accidentally left the oven on and it led to the smoke alarm going off. And next thing you know, the fire department's getting called. That's much different. And those are the types of signs that you should look for in more of a dementia type of process, as opposed to an abrupt acute change in someone's mentation, where suddenly, again, they're real stuporous or suddenly falling a lot because they're unsteady on their feet, or just acting out of character, saying nonsense. When those types of things are happening abruptly, again, that's when you need to call 911 or get to the closest ER or call the primary care clinician. But as it relates to cognitive deficits related to dementia, again, most commonly Alzheimer's disease, that's going to be a slower type of process where you start to kind of recognize, wow, they're slowly becoming more confused. They're slowly becoming more forgetful. They're slowly having some personality changes. They're slowly not able to meet their basic needs, right? Maybe you're noticing their dress looks off. Their hygiene is changing. Maybe they're malodorous. Maybe you're recognizing they're having skin breakdown, more self-neglect. Those are signs that maybe there might be something cognitively going on.
Earlier in your presentation, you referenced the stigma that comes along with mental health. I think that's especially prevalent in our older generation. They don't recognize that mental health issues are, in fact, just issues of the brain that can be treated. How do you delicately approach this subject with your loved one to introduce perhaps some psychiatric element into your loved one's care?
That's a good question, Kelly. Let me just first preface by saying all humans, not just geriatric people or patients, but all humans have some level of defense about them, because anxiety is a human emotion. And we can't deny the fact that anxiety makes us feel very uncomfortable. And sometimes people will go to great lengths to avoid feeling uncomfortable or to avoid examining an unpleasant aspect about themselves. And breaking the ice with that and having an initial conversation on that can be very, very challenging. And it can bring up a lot of different emotions, a lot of different insecurities. And I always tell folks, go with a loving heart, right? Go with empathy. Empathy is much different than sympathy. Empathy is putting yourself into their subjective inner world, right? Sympathy is kind of feeling bad for someone. Empathy is actually trying to put yourself in their shoes so you can try to see the world from their eyes and feel what they're feeling or suffer with kind of what they're suffering from. And if you go with it of, I'm coming at you with concern, I really want to talk about this because it seems like things have been a bit more difficult for you recently. The, the issue that you tend to run into with the dementia disease is the people who are afflicted by it tend to lose their awareness into their own illness. So eventually they might lose capacity to make their own medical decisions, right? Because they're not able to conjure up the recognition that, boy, something is really wrong with me and I need help. And so a lot of times it falls on the next of kin or a family, a relative that's close or a friend, and making those difficult decisions for that person who typically is a bit defiant and oppositional to it can be really, really hard. But it's analogous to kind of parenting, right? You have to do what's best for the loved one if they aren't able to really kind of figure it out for themselves. And that's where that empathy and that compassion and that loving heart can come forward. Be honest, be willing, and be flexible in the approach. Because it can be quite a burden to bear as a family member trying to open up that conversation. It's really hard.
You talked a little bit about how medications can have some strange side effects in our loved ones. Is that another area that you see a lot of development of potential psychiatric issues in older people? And what should family members do?
Well, the first thing that we do as kind of the behavioral health team, that when we're consulted and we come on board, is we do a pretty exhaustive, what we call medication reconciliation. So we look straight off the bat at their kind of current medication list, and we see if there might be a medication that may be contributing to the symptom makeup or contributing to the progression of the disease process itself. And so a lot of what we do up front may be working with the primary care clinician to de-prescribe certain medications, to see if by simplifying certain things, if we might be able to improve the overall demeanor and outlook of the individual. Sometimes that's not enough. And so one thing to point out, right, in our dementia patient populations, there are no disease-modifying treatments out there. And so you have some medications called acetylcholinesterase inhibitors that might be employed to help perhaps slow the progression of the disease, but they don't stop the disease. We have no cure, unfortunately, or real curative treatments for dementia. So sometimes the symptoms that emerge may be psychiatric in nature, like we talked about, and could benefit from psychiatric medication treatment. And so again, we approach every patient from a biological, psychological, social perspective. We intertwine all those layers, and then we determine what are the best next steps as it relates to safety, non-pharmacological interventions, pharmacological interventions, and medical treatment overall.
Many of our families, when they hear that term from the primary care physician, geriatric psychiatry, that can be very scary and upsetting, but it doesn't have to be. Any advice for the families on how to just move past that terminology to help their loved one find the help that they need?
Much like high blood pressure, high cholesterol, diabetes, chronic pain, all those things, we hear them and we're like, oh, okay, so I've got a little bit of high blood pressure, let me go and get treated for it. The fact is that a lot of psychiatric illness is treatable and is no different than your more commonly talked about ailments like high blood pressure, high cholesterol, diabetes. And so with treatment, we can make people feel better. We can help them, become more functional or return back to their baseline status. So I always tell people, right, what are your goals? And or I ask them, what are your goals? What are your current behaviors? Do your current behaviors marry up with your goals? Well, I want to feel better. And the current behavior is, but I won't go to a doctor. That creates a chasm. It creates a discrepancy. So I try to kind of slowly narrow that gap. And sometimes a more direct approach isn't as effective, right? Where you need to go and you need to do X, Y, and Z. Well, people's tendency, we're kind of made up to kind of recoil from that initially. If you tell me what I have to do, I'm going to tell you what I'm not going to do. As opposed to, have you thought about maybe that this needs something, as opposed to kind of saying, we're just going to send you to the geriatric psychiatrist, right? I mean, of course, there's going to be a bit of a resistance to that. Or even if you say, you got to go see the primary care doctor, there may even be some resistance to that too. It typically gets distilled down to fear. What are you afraid of? What's the anxiety about here? Let's start to process that and, soften it so that your behavior aligns more with your goal.
Just a point of clarification. We've been talking a lot about dementia as some of the symptoms here, but an older person doesn't necessarily have to have Alzheimer's or related dementia to have a mental health.
Not at all. Not at all. No. I mean, just like everyone else, right? Depression, anxiety, substance use problems, the list goes on. I mean, they're human too. And so that 25% that I quoted earlier captures all of that. And so neurocognitive illness aside, you can have just primary depression or primary anxiety. And we can work to try to address that. We don't force anyone into treatment unless there's an absolute safety concern, an imminent risk to self or others where they could potentially harm themselves or harm someone else. This is all voluntary, right? I mean, people come ultimately under their own free will and volition for primary psychiatric care. It's when they start to develop the dementia, they lose that capacity piece, that some of that just starts to get limited and goes away. But for some, no, they're healthy, high-functioning people who are suffering from clinical depression or clinical anxiety, and they can reach out and we'd be happy to work with them.
And I think that's important. Medication works for mental health.
It absolutely does. That's why it's prescribed, and there is a large body of evidence to support that. We really do work to follow evidence-based approaches here. So you won't see us going rogue or doing anything outside the standards of care here. And again, the individual's voice really matters. And so if their preference is to first try maybe a psychotherapy approach, great. If they're more motivated and geared towards, I've tried the therapy, I'm ready to go down a medication path, then we give them their options. We educate them on as to what their choices can be. And I work with that individual to come up with a safe decision.
Anything else that you'd like to share? Anything that you feel you'd like to cover that we didn't touch upon?
I think ultimately it's just don't be afraid to ask for help. If your gut's telling you something, your gut's typically right.
Thank you, Dr. Manetta, for sharing such important information that can often be a sensitive subject within our families. We appreciate your honesty and sharing your expertise in this field. Do you have additional questions that we did not address in this webinar? Well, this does not have to be the end of your caregiving journey. Simply email those questions to us at asktheexperts@countrymeadows.com or asktheexperts@ecumenicalretirement.org. Again, I would like to thank Dr. Manetta for sharing his expertise, and I'd like to thank our viewers for watching this webinar. Remember, we're here to help. We're here to help you. Make it a great day.